This is such a great topic. I love talking about insulin resistance because it is we'll call it a syndrome or diagnosis before a syndrome or diagnosis. And understanding how we think about theme based diagnostics for your patient is really important. And I also want you to deeply understand why the cutoffs exist the way they exist currently for patients that we suspect have insulin resistance and how we can make good decisions with our patients, whether we decide to flag them and give them the title of having insulin resistance or not, and how that influences the way that we support them with respect to clinical care. So, my goals for today are for you to better understand the diagnostics that we have available for us. And many of these lab tests actually are landing in your lab, meaning that they are done on regular screening with maybe a conventional practitioner or another doctor in your patient's healthcare team. And yet we can interpret them with the lens of looking for insulin resistance as integrative practitioners to help your patient actually be more early identified as being at risk for those microvascular changes or long-term consequences of insulin resistance and diabetes. My background is in clinical decision making and helping clinicians feel really confident about the evidence that we have available to us and how we use that to make the best clinical decisions possible. I do own the Confident Clinician, which is the only clinical decision making support tool for naturopathic doctors and integrative practitioners right now. And we really focus on evidence based support without being industry funded, which is a really important part of my work, is that I'm able to bring you that sort of very agnostic view to the look at the literature so that you can make the best decisions with your patients possible. So we're going to talk about insulin resistance, obviously, today, mostly looking at labs and how to think about labs in terms of patterns. So there's a lot of limitations for how we currently investigate blood sugar. And I'm going to rely on you guys in the chat a little bit to give us some ideas around the things that you notice about the things that influence blood sugar testing in your patients, because it really speaks volumes to why this is such a difficult thing to assess with lab work or with a single lab test. So I'm hopefully going to inspire you today to think about these patients in a little bit more sort of theme-based ways rather than relying on a single lab metric. But I also want you to leave with a new understanding or maybe even being inspired around how many patients we can support if we intervene a little bit earlier in their disease process than maybe has been done in the past. And I know that I am talking to a very receptive group in terms of preventative medicine, but the way we used to think about that progression from insulin resistance to diabetes has changed. And the research has maybe caught up to something that we probably believed all along in integrative medicine, and that your patients benefit from earlier intervention. So my goals for us today is to highlight some of the sort of unique challenges we have in the research with insulin resistance. I want you to understand how we should use cutoffs to predict or crystal ball your patient's future trajectory in terms of their health. Look at the labs. Again, lots of them are landing in your lab after a regular health assessment, and how you can use them to interpret whether or not your patient has insulin resistance. And then think sort of a little bit more critically about how we have a framework for assessing and diagnosing insulin resistance, because not a single test is going to be what changes our mind. We have to think a bit more thematically with respect to our patients. So insulin resistance is tough because it is a syndrome before a syndrome. And in the past, and I have been practicing for a long time, we only really started to flag patients with diabetes once they crossed a certain threshold with respect to their blood glucose, right? Who remembers the days where we didn't even talk about insulin resistance and patients were almost congratulated for having diabetes once they passed a certain threshold in terms of their blood sugar? We then started to realize there was a whole group and maybe a whole decade in a patient's life experience that was showing us that this person was on a trajectory towards diabetes and that they had physiological changes that were consistent in that whole group that were showing that their blood sugar dysglycemia was heading down a path, or it was a snowball rolling down a hill or a boulder rolling down a hill, depending on where you live. Maybe you never experienced snow. But we realized that there was this whole group of people who had this like common physiological change that was predictive of future diabetes, right? And so we flagged them as insulin resistance. They maybe didn't really meet the cutoffs, or metabolic syndrome. They didn't meet the cutoffs for any particular disease process quite yet. They didn't quite have high cholesterol. They didn't quite have hypertension. They didn't quite have obesity in some cases. They didn't quite have diabetes. And yet we could see that there was this underlying physiological process that was common between all of them. And then that common low grade or subclinical experience was actually putting them at risk for future diabetes. And this is the birth of that understanding of insulin resistance. And it's important that we flag patients early. However, it's also important that we don't overflag patients, right? And for any medical condition, we want to be sure that we're not pointing fingers at or labeling patients who don't have the disease or who will never have the disease. And so our caution, especially in integrative medicine, is that we flag the correct people with insulin resistance and we don't call everyone insulin resistant, right? Because there are cons to being flagged with a condition as if you don't have it or if it's not going to be a concern for you in your lifetime. So that's important, and we're going to talk about that. I also want it to be really clear, and this is where you're going to be inspired today, is that our understanding of insulin resistance has changed. We used to think that people moved through this linear progression where we saw a little bit of dysglycemia, a little bit of insulin resistance, but we didn't see the complications of that until much later in someone's disease process. We used to imagine that people walked in a straight line from insulin resistance to diabetes. And as those complications became apparent, whether it was neuropathy or retinopathy or nephropathy, that maybe nothing had been happening for the previous decade. They just suddenly had all of these challenges. But we're now recognizing that beta cell destruction is happening at much earlier in the disease process in patients with insulin resistance than we had previously thought. So where we used to think we had all this time for patients who, have insulin resistance before anything irreversible or bad was happening, we're actually acknowledging that beta cell destruction is actually happening much earlier in that disease process. So we're going to walk these two sides today, and you get to decide if you are willing to be patient and wait and watch patients who are pre-diabetic or have insulin resistance, or if we're going to be super aggressive with these patients and try and halt and stop and prevent disease process from happening. I think we can probably argue on both sides of this fence, and you'll see as we go through here today how important it is that we, again, think about our patients in theme, but we can see that overflagging patients with insulin resistance is maybe not a perfect strategy. But also, if we watch and wait, we maybe are causing some harm in some patients. And this is where clinical decision-making gets hard, is because we're trying to balance the risks and benefits of early assessment, early diagnostics, and early intervention with this particular group, okay? Like I said in some different words here, is that we do have challenges when we're trying to assess a syndrome before a syndrome. Because some people who have whispers of insulin resistance will never progress to being diabetic, and they will never have any health consequences associated with their insulin resistance. And yet, there are some patients that do. So how we decide who should be flagged and who should be treated is really interesting. And I'm curious, if you think about the two sides there, we've got the aggressive prevention practitioner, and we've got the cautious, watchful waiting practitioner. I'm curious which one you are, and I would love for you to throw it in the chat. Do you feel like you're aggressive with these patients and prevention, or are you cautious and you are watchfully waiting these patients until you're really sure that they have insulin resistance? I'd love to hear that in the chat, because what we know, and this is really clear in the research, is that if we shift the diagnostic criteria even just slightly, we capture thousands and thousands of more patients, and there's pros and cons to that, right? And so as we go through talking about the different labs, this is why I encourage you to think more thematically with your patients than hard cutoffs in this presentation, because we have to be careful that we're capturing people at the right moment, that we can have a really positive impact on their health journey. And lots of people are talking about they're generally more aggressive. And I think that's such a really interesting piece, because how we flag patients and how we support them and when in their health journey is really going to have an impact on their future risk. So interestingly, patients that we flag with insulin resistance, about 30 to 40% of them progress over a decade towards having diabetes. And that's quite a lot, right? When we're sharing with our patients the risk of inaction or the cost of inaction, those are probably the numbers that I would bet on, that we're in about a 30 to 40% transition rate over 12 years for patients who have insulin resistance to having full-blown diabetes if we do nothing, okay? That's quite a large percentage of people. That also means that 60% of them-ish don't. And so if you're watchfully waiting and maybe you want a little bit more data and you wait 6 to 12 months doing general lifestyle, you're not wrong necessarily. There is still a good percentage of patients that will never transition to diabetes, even if we just watch them. But this is really the part that I think we want to hit home. And again, this is the part where I want you to be inspired, is that beta cell failure and insulin resistance are happening simultaneously, not sequentially like we used to think. So it's not insulin resistance for a decade and then we have beta cell failure. They're happening earlier. We also know that the microvascular changes that are happening in patients in that prediabetes insulin resistance window is happening earlier in the disease process than we used to think. So again, it's not insulin resistance, beta cell destruction, microvascular changes, complications. It's those physiological processes are all happening at the very beginning and from the beginning. And our biggest challenge, and this is where you come in as these types of practitioners, is that we actually don't have great ways to assess microvascular change. We can't go in there with a microscope and say, yeah, your kidney microvasculature is changing. We can't do that. And so we have to assume that if patients have insulin resistance, they are starting to have some beta cell destruction, and they are having microvascular changes that are worthy of prevention, right? And so this is where maybe that aggressive approach is actually going to prevent some of the complications we see associated with diabetes. So even when patients maintain their glucose levels but have insulin resistance or have other markers associated with insulin resistance, such as central adiposity, we are seeing that microvascular change. And this is really what we're trying to prevent, right? This is really like the downstream consequence of having insulin resistance is this microvascular change. So the clinically visible change, again, I said nephropathy, neuropathy, retinopathy, et cetera, are much, much later than those initial processes that are happening. Those initial processes are happening maybe decades before we see a clinically measurable change. And that's a challenge, right? By the time you go to the eye doctor and we can see it, it's been happening for a long time. And some of those changes are irreversible, right? And especially when we talk about beta cell function, the more we walk down that path of having a loss of beta cell function, the less effective some of our even natural therapies become. There are many supplements, alpha lipoic acid, for example, that probably rely on having some level of beta cell function in order to be effective. And so if we wait too long to intervene with patients, we're actually potentially missing the opportunity and maybe closing the doors on certain treatment options for them, okay? But there's no standard of care to assess these challenges, and there's no reliable way of measuring microvascular change. So again, what we need is clinicians who are armed with the ability to look at the theme of their patient to say, okay, slight hypertension, you overconsume salt, you have sleep apnea, I think you have insulin resistance, or you had PCOS, you had gestational diabetes, you have abdominal obesity, we've got a couple of bad triglyceride readings, I think you have insulin resistance. We need clinicians who are able to look thematically at their patients and understand the cutoffs on some of these ratio-based tests in order to flag these patients early. So this is hopefully we're going to inspire you today to be excited about this. Okay, and the longer the patients are pre-diabetic or diabetic, the more beta destruction that they will have. And this is not news to you, but it's just something worth saying. So what this all means is early assessment and early trajectory change. So interventions can vary in terms of aggression, right? We might prescribe the Mediterranean diet and exercise in everybody, whether they're insulin resistant or not, and that would be considered to be an intervention. If you're considering supplementation every day or other solutions, off-label medication, et cetera, we may be looking at those being more aggressive interventions as we talk about this patient population. But many patients would benefit from the basic recommendations to reduce insulin resistance, no matter what their lab work says. And I'm sure we can all agree on that. Okay, so we're going to try and use lab work as a crystal ball. So every individual lab test is not super helpful. And this is where we struggle with this particular assessment, is that what probably is the case is that there are multiple phenotypes of insulin resistance and multiple phenotypes of dysglycemic diabetes that we have not yet really been able to well categorize or capture, okay? So my question I always consider with clinicians, like, is your lean patient with an overnight elevated fasting glucose the same as your overweight patient with an elevated glucose after oral glucose tolerance test, right? Like the answer is no. One patient has hepatic insulin resistance that is perhaps like heavily genetically driven, whereas the other patient has more peripheral insulin resistance that maybe is more likely to be impacted by lifestyle. So, when we're thinking about insulin resistance and diabetes, to date, we have not done a great job of separating those two people, right? We run all the same labs in them, we get all sorts of wacky results back, and then we're sometimes confused why certain labs get better and other labs don't using the same interventions. And what is likely true is that there's more than one type of insulin resistant patient or metabolic syndrome patient that we've not yet really been able to tease out. And that's why I don't like to rely on a single lab test. Think more thematically when it comes to your patient, because we are likely talking about a few different phenotypes and we're trying to use their history and labs to predict the future. Okay. Like I said, we're trying to flag an at risk person versus trying to flag someone with a medical condition, right? When we have really hard cutoffs, like we do for diabetes or like we do for, say, infections, it's yes, no, the light switch is on or off. And with insulin resistance, we're trying to predict future risk ratios. We're trying to combine all the things we think about this patient to estimate future risk. So that's why it's a little bit of a different way of thinking about how to pool together this information. And I know I've said the same thing over and over again, but it's because it's a really important way for you to communicate with your patients as well. That's why insulin resistance, they can see you and then maybe they see another practitioner. And they might get two slightly different answers about how risky we think they are. I always think the longer you talk to patients, the more you'll find in their history about their insulin resistance. If they have a 2-minute visit with another practitioner, they might arrive at a different answer. So for your patient and you to understand that we're talking about a whole health history, a whole genetic history, a whole thing here to make this decision is quite helpful. And it's not yes, no, on, off. Other conditions can feel when we make diagnoses. So I put this next slide in here just to help you with your question asking when it comes to history taking. But these are all sorts of assessment tools that have been created with respect to assessing insulin resistance. And so they've broken them down in terms of your demographics, looking at medical, and then looking at lifestyle things. So you can see like there are many validated or invalidated tests trying to figure out the link between these things and insulin resistance. And so if you're not asking about hypertension, if you're not asking about gestational diabetes, if you're not asking about macrosomia, right? If that person themselves was a large for gestational age baby, these are things that you should be asking in your history. I put this in here just for completeness. I don't want to spend a ton of time on it because our focus today is on the labs. But these are great assessment questions that you can ask with respect to health history and lifestyle that give you an indication for whether or not people have insulin resistance based on questions that you may ask them. And I have another little summary in another slide. I also put these next two in here for interest and completeness as well, is whether or not stress causes insulin resistance or just straight up aging causes insulin resistance. And both of them, the jury is a little out. We know that stress influences not just your biochemistry, but also your behavior. And it's very hard to separate out the stressed out person who eats differently, doesn't sleep, and doesn't exercise from the biochemistry of being stressed. And so we do know there's a connection, but we don't know what is the chicken and the egg around that. And then similarly around aging, if we lose muscle mass, we influence insulin resistance, of course. And so is it aging? Is it sarcopenia? Is there an actual chronology issue with respect to aging that influences insulin resistance? Or is there another mechanism that's common to aging that we see that's influencing insulin resistance, which is probably the case. But I put these two slides in here for interest, and also it gives you the references if you want to go back and have a look at them yourself. And then this is a diagram from that one particular slide or paper that was looking at the factors that are associated with aging that influence insulin resistance. And it's just a great reminder. I love these studies that have great methodology because they can teach us a lot about how to conduct a visit or assessment with your patient. And this was a great thematic for how to think about your patient's entire health history to help differentiate whether or not it was age-related changes they were having or if there was another factor that was influencing their insulin resistance. This is why you're here, like the meat of it is the tests. So every test that we use for blood sugar and insulin has pros and cons, right? And I'm sure if I asked you in the chat and said, what are the things that can influence a fasting glucose? You could probably tell me 5 or 6 things that would influence a fasting glucose. If I said, what influences your CGM? You could tell me maybe 150 things that influence a CGM reading. If I said, what influences hemoglobin A1C, right? You'd list a million of them, maybe most importantly, anemia. So every single test that we look at for blood sugar can be volatile, right? It's different than doing a throat swab for strep and we're like pretty darn sure if it's positive that bacteria is in there. These tests actually are a little bit more volatile because they're influenced by time of day, by sleep, by other factors, by last meal, by the composition of the last meal, by muscle mass, right? Like we literally can influence these tests by many physical and lifestyle related factors. So, how on earth are we supposed to put all of our money behind a lab test that is influenced so significantly by a patient's day to day activities? It's hard. And that's why our clinical decision making gets a little hard and why it does need to be thought of a bit more thematically than us relying on a single test, because a single test can be quite influenced by a lot of things. And so, what you'll notice in the research on insulin resistance is that we've tried to normalize some of these tests by using formulas or by using constants to try and help drown out the noise that we see from these relatively volatile tests. That's why you'll see things like the invention of the HOMA-IR scoring or triglyceride to glucose ratio scoring. It's because we're trying to quiet the noise between two tests that are influenced by time of day, et cetera, et cetera. The other thing is that some of these tests are actually testing two different things. So your hemoglobin A1C and your oral glucose tolerance tests are actually looking at different phases of the insulin and glucose pathways. And so again, we want to look at all of them and we want to look at the entire health history of our patient so we can try and understand the story here around their blood sugar versus us, again, relying on one test. And I'm sure you've all had that experience where patients have had a fasting glucose and a cholesterol panel and everything looks fine and they're told that everything's great and they don't need to make any changes. And then when we start to look at them a little bit more deeply, we're like, wait a minute, I think I can see whispers of insulin resistance in this lab work. Okay. So even if the labs all come back normal, but your patients are starting to accumulate a story that sounds like insulin resistance. So they have abdominal obesity, they have hypertension, they have sleep apnea. We probably would still flag them as being at risk for diabetes and having insulin resistance, even if their tests come back normal. We are at the mercy of how tests get run in your jurisdiction. Not every oral glucose tolerance test gives you every single metric for every single hour. There's lots of things for us to consider when you get those labs back, whether or not they're actually supporting the decision that you're trying to make. Okay. So this again is just a great thematic that sort of reminds us that there are different pathways, different lab tests, and different mechanisms of action that are influencing each of those numbers, right? The reason that triglycerides are elevated is different than the reason that insulin is elevated. And do they throw fire and gasoline on each other? Yes. Peripheral insulin resistance is different than hepatic insulin resistance. And so they're going to show up positively in different tests and maybe even in different patient prototypes, but they still are requiring the same kind of treatment and support that we would give each other or give those two different patients because the underlying consequence is going to be the same as far as we understand it right now. Okay, so I put in some of the assessment. Of course, the history taking, we talked about that, some of the labs that you can consider. I put a question mark beside CGM, which maybe is going to earn me some enemies, but I'll show you why in a second. Just from an assessment and diagnostics perspective, we don't quite have the validated measures we need or that we would like to see or that I would like to see quite yet. And then, of course, there's some physical exam things that you can do in your office to give you more proof and more weight behind whether or not someone is assessed with insulin resistance. Okay. So as far as screening goes, and screening is a whole other conversation, right? There's pros and cons of en masse population level screening for every medical condition. But right now, we do recommend screening individuals for insulin resistance and prediabetes and diabetes. The U.S. Preventative Task Force does recommend annual screening in patients who we think are at risk for diabetes. Where things get a little less clear is the patient who doesn't appear to be at risk at all. So do we run a random fasting glucose on every patient who walks in the door? Should we be screening for insulin resistance in everyone? Should we do it annually? That's where it's a little less clear. It's very clear cut in the guidelines what we do with patients who have a pre-diabetes diagnosis and have obesity. But it's our otherwise walking well patients that there aren't clear guidelines. But these labs, again, if they land in your lap, have been associated with increased risk of insulin resistance. And so if we look at all of the ratios here, and we're actually going to go through each of these so you feel confident about all of them, is that we've got the crude lab test itself, And then we've got some ratios where we're trying to, again, quiet the noise between some of these volatile labs. But one or two of these may land in your lab and may show you that your patient is pointing towards having insulin resistance because of these lab assessments. So I said this earlier, but for example, we may get a positive OGTT, but then everything else might be fine. We might get an elevated plasma fasting glucose, but then everything else might be fine. Those are probably two different patients who maybe have two different underlying mechanisms or pathophysiology. This is why we need time, we need good history taking, and we need a battery of tests in these patients rather than focusing on a single one. Okay. The other thing I say here, which I think is really important before we go into talking about labs and talking about tracking glucose over time, is that I always take this opportunity to remind clinicians that the language that we use to describe what's happening, like as part of normal physiology, is really important. So we actually kind of want things to spike after a meal because that's being released, right? We really should have a post meal response to the foods that you're eating. And sometimes, especially in the online space, we'll start to use words that sound like we vilify some normal physiological processes that are happening in the body under normal circumstances, like eating a banana. So I do think it's really important that we don't use the word spiking to describe normal physiology. For certain, patients can have an exaggerated release of insulin post meal, and we do want to try and capture that and catch that with respect to assessment. But really important that patients understand that their body should respond when they have a meal, and we are looking for spikes of certain hormones and certain processes after they eat. Okay. So, when we're making a decision about running labs, it really needs to tell us something we don't already know or change our treatment. I give this little disclaimer before we talk about any assessment or any labs. Labs for glucose are cheap, easy, accessible. So, I don't know if you're going to go through a massive decision making process before you decide to run a hemoglobin A1C. It's an easy and accessible test. But for many of our patients, the day we meet them, we might be able to see that they have insulin resistance based on all the other things we've talked about. And what's really important around this discussion is that we don't wait for labs to initiate some support or some discussion. Because if you can tell that your patient has insulin resistance without all those labs, or maybe labs are out of scope for you and you have to refer for labs, you can help support your patient with nutrition and exercise change before you get lab work back. But for me, this is where I would maybe consider doing additional, I call it kitchen sink assessment, where I would want the full gamut of all of the labs to help better understand that patient, especially if patients are collecting indicators that would make me highly suspicious that they have insulin resistance and I need their entire health team on board, or perhaps I think that the patient needs a more aggressive approach and the lab work can help justify that kind of approach that you're going to take. When I wouldn't bother doing additional labs is if it's like the writing's on the wall, the patient's on board, I don't need to track things going forward. I would initiate treatment before I even get some lab work back. Okay. So this is just a slide that reminds us that the gold standard for assessing beta cell destruction and insulin resistance are actually euglycemic clamp style labs that are run in a hospital setting or in a laboratory setting, which is frustrating, right? Like the literal gold standard is something that is not accessible to us as clinicians and not practical. And so we've had to use other assessments in order to try and proxy this effect. Okay. And that's always difficult when the actual gold standard is not possible. And now we're using a proxy to try and figure out if our patient has insulin resistance. And so I said this earlier, but each individual test is relatively volatile. Glucose, even A1C, right, can be affected by lots of different factors. Where we gain some confidence is by using ratios and formulas or by tracking trends over time. So rather than using a single lab test, we're combining two lab tests in a ratio, or we're tracking a single lab test over multiple readings. I don't think I would congratulate patients for having insulin resistance if I got one hemoglobin A1C of 5.6. Okay. I'd want to see that maybe repeated more than one time. I also would maybe want to see two lab tests that were a bit abnormal before I jumped in with aggressive care and treatment. Okay, so here are the examples: your fasting glucose, CGM, fasting insulin, a single blood pressure, right? These are volatile tests that could be influenced by the time of day, stress of the day, etc. And when we look at the ratios, we've got things like HOMA-IR, triglyceride to HDL ratio. triglyceride to glucose ratio, which is emerging as maybe the most stable of all of these ratios and assessments. And then, of course, trending over time. If we can see that patients are walking down that path towards diabetes, we would want to intervene. Okay. So fasting insulin and fasting glucose are really looking at hepatic glucose release overnight and that mismatch between hepatic insulin resistance, overproduction of glucose or release overnight, and then a mismatch in terms of like beta cell production of insulin, because as far as it's concerned, there's a ton of glucose going around because there is. And that's where we get that mismatch and we get both elevated glucose and elevated insulin. Again, both of these tests are really volatile, and reading either one of them on their own is not particularly helpful, which is why we consider using something like HOMA-IR instead, okay? Oral glucose tolerance test, which I'm sure that you have seen. Depending on where you live, you may or may not get back the kind of data that we're super excited about with this one. But this is actually looking at your response to a meal, okay? So big difference between our fasting hepatic insulin resistant levels that we get from our fasting overnight glucose and insulin versus our OGTT, which is looking at our fasted state, but then the experience after we provide a glucose load to patients. And it helps us understand patients' ability to normalize glucose after a load, but it also helps us understand like various phases of that insulin release depending on how many metrics we get in that patient's OGTT test. I know in Ontario, they've moved to a 1-hour OGTT as a more common assessment, and we have to refer patients back for a 2-hour. We may or may not get that additional information that we're looking for. But interestingly, and this is a really neat study that actually, remember I said earlier, there's probably a few different phenotypes of patients with various types of insulin resistance. This paper actually looked at what if they're insulin resistant, but normal glucose tolerance. What if they have normal glucose tolerance and not impaired insulin resistance? They actually segregated patients by 4 different phenotypes to see what was happening over the course of their OGTT. And I'm going to leave this one with you so that you can look at it at a later date. But it's a really interesting thing because sometimes we get back some normal tests and some abnormal tests, and it's hard to interpret or understand if our patient has insulin resistance or not. So they basically looked at, we've got these patients here, they were insulin sensitive with normal glucose, right? And so if we give them the OGTT, we expect everything to happen perfectly. Then we have patients who were insulin resistant, but they had normal glucose tolerance, right? So their glucose was normal, but they had an exaggerated insulin release after a meal, okay? So those patients exist, right? Their fasting glucose was fine, but they have an exaggerated insulin effect after a meal. We then had patients who had elevated insulin after a meal and impaired glucose disposal, so it was still elevated after a meal. So those are like 4 different kinds of people and 4 different patients. Right now, we treat them all the same, but their OGTT actually is coming back a little bit different. So depending on how specific that OGTT is going to be for you, it might help you gain some additional intel for what your patient is experiencing and where in the process they are actually having the breakdown. So this was the diagram from this particular paper. But the patients who had insulin resistance but normal glucose, their fasting glucose was normal, but their fasting insulin was 3 times the level that we would have expected it to be. In the patients who are insulin resistant but had normal glucose, their insulin was much higher than we would expect, but their glucose was normal. So we weren't going to catch it on a glucose-only test. We're only catching it if we do this multiple phase assessment, where we're seeing that their levels of insulin release are more than double or triple what we would expect, but their glucose was actually normal, okay? So you can see that this test alone actually can give us quite a lot of intel if we get all these time points, but depending on where you live, you may not actually get all of these time points. This is a great reminder that there's a lot of things that influence an OGTT. Like we said earlier, every test is a little volatile. So important to consider that depending on your patient's like pre-state, if they're tired, if they have exercised, if they are not well hydrated, that can all influence their OGTT. So similar to all the other tests, even though I quite like this one, it can be influenced by factors that are outside of the lab's control and maybe related to the patient. So HOMA-IR is, again, trying to quiet the noise between glucose and insulin and quiet the noise, that volatility between those 2 tests. And I used to rely on this test a ton. There was a time where this was the best ratio that we could come up with to try and predict insulin resistance because it was the only one that we had studied. And you used to have to use like specific HOMA-IR calculators online. Now you can just ask ChatGPT. You can say, my patient's glucose is this, their fasting insulin is this, what's their HOMA-IR score? And it will tell you. This used to be the best ratio, and it's now not the best ratio. The other two, HDL and triglyceride to glucose, are now more stable reference points. But this was historically our best ratio to use. And those labs were sometimes landing in your lap, right? Where someone had the assessment done, but no one had looked at it critically to compare their fasting insulin against their fasting glucose. So looking at this HOMA-IR, the real question is, what do we think the cutoff actually is? And so for many of the studies floating around right now, we think anything over like between 1.8 and 2.1, depending on your gender, depending on your age, depending on other risk factors, is pointing us towards that insulin resistant concern. There are some ethnic groups that walk around with slightly higher HOMA-IR scores that never progress to diabetes. However, if we look like population-wise, we're probably looking around 2-ish as a cutoff, where we're going to say that anything above that is maybe giving us a signal that patients are more at risk for insulin resistance and diabetes in the future. Like I said, the targets vary. Ideally, we want below 2.1. I think 2.5 is maybe a slightly higher target. And anything above that is giving us some suspicion that the patients are on their way to developing future type 2 diabetes. But I say in the last bullet here, we have better ratios. We have more stable numbers than we used to have just with looking at HOMA-IR. And although this used to be the primary assessment and target tool that I would use, I've now retired the use of this particular ratio. You'll still see it talked about in papers, especially papers on PCOS or other papers were acknowledging insulin resistance as part of that disease process. You'll see HOMA-IR stated. And so I didn't want to leave it out, even though I think for you, you're probably going to lean on some of our other assessments instead. So hemoglobin A1C, of course, we know of this one. This is one that's we learned about like way back in school. What I do want to call out is that there are many things that influence hemoglobin A1C levels, maybe most importantly being things like iron deficiency. And so iron deficiency actually increases hemoglobin A1C. And so we don't want to accidentally diagnose someone as having diabetes or insulin resistance when actually they have iron deficiency. But again, it's another example how one lab test can't be the end all be all with these patients. And we really want to make sure that we are looking at the entire theme of our patients with insulin resistance before handing them that to diagnosis. The cutoff for hemoglobin A1C is above 5.5. I have a great paper in here if you are curious about how low can we go with hemoglobin A1C. We don't need to push those levels any lower than 5.5. This is an exceptional paper. It's a little bit of an oldie, but it's a goodie that looks specifically at where hemoglobin A1C becomes problematic or becomes risky. And it's when the line crosses that 5.5. So anything above that, we're going to consider our patient to be at risk for diabetes and have some level of insulin resistance. Anything below 5.5, and I wouldn't worry about that particular number. We maybe wouldn't need to focus on it. So that's just the chart from that particular paper. Okay, so now we're into the good ratios. So both triglyceride to HDL and triglyceride to glucose ratio are emerging as more stable assessments for looking at insulin resistance. And part of that's because these numbers themselves are not quite as volatile. So when we combine them, it's even less volatile. Whereas when we think about HOMA-IR, fasting insulin changes like every second, and fasting glucose is influenced by lots of things. When we combine those two numbers, we're not quite as confident. But when we start to combine these numbers, especially triglycerides to glucose ratio, we're actually talking about the underlying mechanisms that are related to insulin resistance, right? Like elevated triglycerides due to those free fatty acid release in the adipocytes who are being affected by insulin resistance, and then the elevated glucose. Those are the things that are part of that mechanistic challenge that's happening with insulin resistance. And so when we measure them and we can compare them, we are doing a much closer job of assessing patients' insulin resistance with those numbers. These are the numbers, and I gave you some of the cutoffs. And the interesting things about this is that even if patients have like normoglycemia or relatively okay-ish blood sugar, but elevated triglyceride to HDL ratio, we are still seeing increased risk, and we're still seeing that progression to diabetes, even with fine-ish blood sugar. So it's a great reminder that one lab test does not put people in the clear and one lab test does not diagnose people. We want the theme. Okay. That's what you're walking away with today, is remembering the theme. So the cutoff is usually about 3, and it's measured as 3 in many guiding documents. I used to be okay with that number, and now I'm not. The recommended numbers have actually dropped a little bit, around like 1.8 to 2-ish. So if you plug those numbers in, and I again would just ask ChatGPT, what's the triglyceride to HDL ratio with these two numbers? And it will show you. But if you plug that in, we want it to be below 2. We are still seeing increased risk of progression to diabetes. Many of the guidelines still use 3 as a cutoff. I don't think that's appropriate. So for example, this is a great, more recent study looking at like biobank numbers. And we saw a risk factor in progression for cardiovascular disease in patients who had a ratio of over 1.9. So I want to bring that cutoff down for us closer to 2 and not 3 as previously thought. This is a brand new assessment that combines HDL to triglyceride ratio and BMI. Again, trying to normalize or reduce the noise that we see in some of these ratios. There's not very many papers on it, but I wanted to put it here for you out of interest's sake, because they do think it's actually becoming a little bit more of a specific and sensitive test than looking just at HDL to triglyceride. And that's the formula for you. And again, you can just ask ChatGPT and it will spit it out for you. Okay, so this is the new one, the triglyceride to glucose ratio. And I've presented on this topic every single year for the last 3 or 4 years. And in 2022, we had one good paper on this discussion and really nothing else. It was not in any guidelines. And now all of a sudden, we have a lot of papers, and this is considered to maybe be the most accurate assessment for insulin resistance that exists right now. Really cheap, really easy to calculate, and also lands in your lap a lot of the time. Patients are having this lab work done on a regular basis, right? And then you can use it to assess. So when we see this elevated number, patients have an increased risk of transitioning to diabetes. We've studied it in kids, we've studied it in adolescents, we've studied it in adults, and it concords well with many of the other assessments that we've used in the past, like OGTT. So if this is a new one for you, this is the formula, okay? So it's like the log of fasting triglycerides times fasting glucose over 2. Ask AI to do that calculation for you, but that gives you the index. So the cutoffs are somewhere in the like 8.1 to 8.4-ish range. And this will likely get clearer over time. We have to remember we only have about 20-ish papers on this particular ratio right now, but it's somewhere in that 8 to 8.4 range. And so when we use that range and we see patients above it, they have a higher likelihood of transitioning to diabetes, a higher likelihood of having complications associated with that diabetes, and then higher complications associated with cardiometabolic outcomes as well. So we want to decrease that number. Anytime we see something that's having a prediction around major adverse cardiovascular events or MACE, that's an important number for us to pay attention to, because if we can change that, we can maybe change patients' long-term health trajectory. So really important one. And hopefully you can use this with your patients. I throw uric acid in here only because it's a neat and maybe a little bit functional medicine assessment for insulin resistance, but we do see increased risk of insulin resistance in patients who have elevated uric acid. We've all had that patient who has gout and they're like, I swear there's nothing else going on or nothing else wrong. But we do want to use this as maybe part of a comprehensive assessment for patients. Or perhaps this is a first flag that patients walk in our office with gout, and it reminds us that we should be exploring insulin resistance in that patient a little bit further. The last thing I want to talk about here, which is not a lab test, but it's a physical measure. This is such an important piece for us to pay attention to. So this is just an absolutely brilliant paper. It's one of my favorites. When we look in research, we always want to look at what happens if we stack things on top of each other, right? If patients have elevated this and elevated this, or they have elevated this and they have sleep apnea. So this was a brilliant paper that took all the measures related to insulin resistance. So triglyceride to glucose ratio, triglyceride to HDL ratio, and then their definition of metabolic syndrome, right? Meeting the diagnostic criteria for metabolic syndrome. They then said, what happens if patients have a normal weight or normal waist circumference versus an elevated waist circumference? So what happens if we combine waist circumference with that thing? And what they found is that the odds ratio of that patient having more additional risk factors associated with that, the progression to diabetes and cardiovascular disease, was many times enhanced when patients had one of these markers plus elevated waist circumference. So if you look at this, that the triglyceride to glucose ratio high, so over 8, if they had high waist circumference, they had 20 times the risk and outcomes versus patients who had what was considered to be the normal waist circumference. So for you, as you're trying to pull together this theme and this story for your patients, but we have one elevated lab test, we have to remember that we're also looking at it in context with all of their other physical measures, their health history, maybe their genetics and family history to help us paint this picture. So even if we only have one elevated lab test, but we combine that with a physical measure, we're really easily able to predict future risk for that patient. And on this next slide, I put all of the waist circumference cutoffs by ethnicity because it does differ depending on where patients are from. Okay. Lastly, here we've got our good old CGMs. And I'm not into CGMs, but I am really interested in the cautious use of lab assessment, especially when it's point of care, meaning that like patients can buy lab assessments over the counter. We certainly want to interpret the information with caution. So where the research is with CGMs right now is that they very interestingly influence behavior change, right? If we put a CGM on patients, they dramatically change their eating behavior. They dramatically change lots of things about their behavior and can dramatically influence those CGM readings over a very short window of time. There's a really neat little paper in here that talks about how useless the first 14 days are when patients put on a CGM because they just eat like totally differently in those first 14 days. We also generally see change if we put two different CGMs on patients. We see a discordance between those two machines or those two types of CGMs. And so it's hard for us to draw a line in the sand and say, this is the number, this is what's important when we see dramatic differences between units. We see dramatic behavior change in patients. This was a great study that if patients looked at their CGM reading less than 1.5 times per day, their glucose was higher. And it had nothing to do with what we educated them on. It had nothing to do with what we told them to eat. It was like, how many times did you look at the app? And if they looked at the app one time, they didn't change their behavior. And if they looked at the app 3 times, they did change their behavior. So I'm really curious about it as part of like behavior change strategy, which is something I'm really interested in. But when we look at what is currently, this is the one with the 2 different CGMs. When we look at where the research lies right now for using CGMs to predict insulin resistance and future diabetes, the research is really not quite caught up for us to reliably be able to put our finger on what it's saying. So this is our most up-to-date assessment of where the CGM data is. You can see that there are studies that are like 10 days long. There are some studies that are a year long. Most of them are not controlled, meaning everybody got a CGM. And so for me as a researcher and someone trying to help you make good clinical decisions, you have so many tools at your disposal that you don't need to reach for this quite yet until we have better standardized process for figuring out what we think about these numbers. The triglyceride to glucose ratio is maybe like my most favorite assessment at this point, combined with the patient's full health history, et cetera. But this is where we live right now with the CGM data. In summary, here's what I want you to walk away with today. The diagnostic criteria for type 2 diabetes is super clear. The diagnostic criteria for insulin resistance is a little mucky, right? We can assume insulin resistance based on so many factors that patients may present with. We have labs that are pretty decent at assessing glucose, except they are affected by lots of things. We have some ratios and calculators that help us even further. And that's really where I would put my money going forward, is looking at some of these standardized ratios that are helping to make sense of relatively volatile labs. Okay. We also know that rather than patients progressing from insulin resistance to beta cell destruction, they're happening at the same time. So finding and flagging this theme in your patient earlier than maybe if we just left them on their own or if they just wandered through conventional care without additional support, we actually have quite a role to play in early assessment and early support for these patients so that we can prevent those microvascular changes from happening much earlier in the process. We're trying to use their health history and their labs as a crystal ball, like I said, to try and figure out what's going on with them and predict their future based on their current situation. And so the more that you can collect, it's showing that there is some level of dysglycemia or some level of exaggerated insulin response or some level of mismatch between triglycerides and glucose, it can really help you paint a picture for your patient what might happen if you don't make change and don't intervene. So the questions I would ask myself, and you guys were all quite thoughtful around wanting to be more proactive, right? I use the word aggressive. Aggressive naturopathic medicine is really just being proactive. So the questions I would always ask myself is like, how risky is this person? Am I comfortable leaving them without treatment? And for how long? How long would I leave them with general recommendations before I would consider being more aggressive or wanting to intervene? And then how do we avoid overtreatment, right? Is it possible to apply some support for your patient and then reassess versus us jumping in with a kitchen sink and the patient losing steam or not being able to make those behavior changes? I think that's another really important part of the conversation is, can we apply minimally invasive support for a patient to change their trajectory without overtreatment? So we said a lot of these things in summary, but I want to make sure that we can answer some of the questions that are in the chat. But really, it's about reading some between the lines a little bit, which we've always been great at in integrative medicine. I just want you to leave with some of those cutoffs and understanding why we use those ratio calculators instead of crude numbers to paint a better picture for your patient so that you can feel confident in that assessment.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.